candid conversations about menopause.
Good evening and welcome to my channel. This evening, we will be talking about that dreaded word, menopause. I know when I reached 49, yes, 49, I started my perimenopause. And I remember waking up one night and my heart was beating really, really fast. And my entire night clothes were soaking wet with perspiration. I had a lot of night sweats. I was hot all the time and I felt confused. Talking about brain fog, I remember looking for my glasses and my glasses was right on my face. My glasses was right on my face and I was actually looking for my glasses. And there are times that you feel so, insecure yourself because, you want to go somewhere, but you are afraid to go because, you're going to have a hot flush. It affects your emotional health.
Donna Klassen. I am the co-founder of Let's Talk Menopause. And Let's Talk Menopause is a new national nonprofit organization, just started last year, and we're invested in changing the conversation around menopause so people get the information they need and the health care they deserve. We have with us Jessica Levin, who's the director of Menopause Talks, and she is going to take it away with explaining about Menopause Talks and what this one is, and also some housekeeping.
Great. Thank you, Donna, so much. And welcome to everyone. Some people are still joining, doing the poll. We are so happy you all are joining us today. And we are thrilled that we're joined by two renowned experts on the topic we're addressing today, Dr. Maria Uloko and Dr. Rachel Rubin. And we're actually going to let them introduce each other because they know each other so well. But suffice it to say that as practitioners and researchers and educators and incredible advocates for women's health, they embody everything we're trying to bring to you during our Menopause Talks series. I wanted to do a few housekeeping items, and then we will turn it over. To them. So we've actually asked them today to do something a little differently. We asked them to do two case studies. So essentially to take us into their office with them and describe real life scenarios with real patients, anonymously, of course, and their symptoms and what treatment options they explore with them, because we think this is going to be highly relatable to many of us. As you could see from the poll, a lot of us on this call are experiencing many of the symptoms that they are going to describe in their case studies. So after each case presentation, we're going to have questions and answers. So please just send your questions throughout and we will try to get to them, as many of them as possible. The chat will remain closed during the webinar, so definitely use the questions and answers for your questions. And at the end, we have a brief survey we're going to ask you to fill out. And then we're going to share with you a takeaway information sheet from Dr. Rubin and Dr. Uloko. If you have to leave the call early, we will send you a follow-up email with the survey and the information sheet as well. So welcome. We're so excited you're here. And now I'm going to turn you over to Dr. Uloko and Dr. Rubin. Thank you for joining us.
Well, hello.
Hi.
It's good to see you. How are you? How is the West Coast right now?
It is good. I just emergently stented someone, and now I'm here talking about something I love just as much.
As someone who has had a kidney stone, I thank you for what you do for humanity. I can start. I'm going to introduce Dr. Uloko. She is my friend. She is my fellowship sister. We trained together. I'm a few years older than her, so I feel a little like a big sister. And I'm so proud of everything she has accomplished. And I absolutely adore working with her and know us in this field together. There are just many roadblocks ahead, but we're going to just take away them all. She is a board certified urologist who specialized in the treatment of female sexual dysfunction, female sexual pain, low libido, hormone therapy, and more. She's fellowship trained to take care of all genders. She empowers her patients to take ownership of their sexual health by providing a shame-free space to ask questions and share their stories. She also seeks to close gaps and disparities of care and implement systems that promote diversity and inclusivity. As an assistant professor at UC San Diego School of Medicine, she trains medical students, residents, and fellows in urology and sexual health. She trained at the University of Missouri, Kansas City School of Medicine, and did her fellowship training at San Diego Sexual Medicine, which is where I did it as well as Scripps. So I'm just the luckiest to have her in my life, and I'll let her introduce me.
Excellent. Hello, everyone. My name is Dr. Uloko, and I have the esteemed pleasure of introducing Dr. Rachel Rubin. Like she said, we are fellowship kin, and she was a couple years older than me in her training course. And in the field of urology, it's a very male-dominated specialty, and Rachel has been such a voice of reason and passion and advocacy for the advancements in sexual health within the urologist space. She has single-handedly taken the AUA, the American Urologic Association, to task on making sure that we are inclusive and we care about sexual health when it comes to all genders. And she has single-handedly taken that realm, and it is so amazing that I even get to be considered in the same space as her. She did her medical school training at Tufts and then went on to do her urology residency at Georgetown, where she's also assistant clinical professor now, as well as she just opened her own practice. Y'all, this woman can do it all. She is truly just such a passionate advocate for her patients. She wants to change the field of medicine, and we're working hard so that we no longer have to have these webinars, so that everyone knows what to do when you come in with menopause symptoms. And so I'm just so happy to be in this room and share the information that we know with someone that I love dearly.
Well, I blush away. This is so fun, and I'm very excited to do this with you. So do we have, I don't have slides for, my case is number 2. Do you have slides for your case? Can we pull those up?
Let's do it. So as someone that specializes in comprehensive sexual health, and a lot of that includes menopause management, this is a very common case that I see weekly. So we'll start out with the case. It's a 64-year-old female, very healthy. She presents for evaluation of pain with sex and recurrent urinary tract infections. She had stopped having periods right around, so she started menopause right around 51, and did HRT for several years, and then stopped once she felt that she was no longer symptomatic. But over the last couple of years, she's developed severe pain with sex, vaginal dryness, and as well as recurrent urinary tract infections. She's been having infections every 2 to 3 months, and just can't seem to clear them. She also reports some vulvar itching, and really this pain with penetration has been preventing her from being able to be intimate with her partner. So this is something that we see quite a bit when it comes to menopause and symptoms. And so when we think about the vulvar and vaginal health, we really have to understand what menopause really means. So menopause essentially means that your ovaries are no longer producing hormones. But the thing is with the vaginal tissue and the vulvar tissue is that those hormones are very needed in order for them to work optimally. And so although this patient was taking HRT, systemic HRT, to help with her systemic symptoms, she then stopped taking hormones. So now she's no longer on any hormones. And ultimately what then happens is that if you're no longer taking hormones, if you kind of think of things like a garden, as you know, with the pandemic, we all have had flowers and plants, and we've all forgotten to water our plants. And you know what happens when we don't water our plants? They get angry and they die. And that's essentially what's happening to the vulvar and vaginal tissue when you don't have any hormones present. And so, you don't necessarily need to do the systemic hormones. She's kind of aged out of the systemic hormones for herself, but we're big believers in local or vaginal hormones, and really big believers in vaginal estrogen, and then as well as testosterone. Those are two major hormones that we really that we direly need for our genitals, in order to function well, in order to maintain its natural health. Without those things, essentially these symptoms will occur. And so when we think about the length and the duration of taking these vaginal hormones, I think it was Rachel actually that said you should be buried with your tube of vaginal estrogen and testosterone, because really it is what is watering the garden, watering the plants. It's keeping your tissues healthy and vital, and it's preventing these serious complications that can be prevented with just twice weekly application of these vital hormones. Rachel, what are your thoughts on this very common problem that we see?
Well, I couldn't agree more, and I think that what I say is till death do you part, and the reason is that this is not just about sex. Dr. Uloko and I are sex doctors. We are trained sexual medicine specialists, but we're urologists first and foremost. And urinary tract infections can kill people. They can kill people. You get sepsis, and if you're 90 and you get sepsis, you can go into the hospital. You could have antibiotic resistance. It can be lethal. Say you have a hip replacement and you get an infection in the hospital from a catheter, that can be lethal. Say you are getting up at night to pee all the time and you slip and break your hip, then you're 80 years old, that can be lethal. And vaginal estrogen or vaginal hormones, and we use either DHEA or estrogen typically, those can be life-saving. And so whereas, yes, it will absolutely help with sexual health and lubrication and orgasm and your ability to have penetration if you want it, it's actually not just about penetration. I don't care if you penetrate ever again. That's not your partner is not my interest right now. What I care about is bladder, urethra, vaginal, and urinary health. And I'm a big believer that it's the only essential oil out there. And I think your gardening analogy is very good, because if you don't water the plant, it gets droopy, and then you water it and boom, it perks right up. And so we don't want to treat you when it is irreparable, when we can no longer get it to perk back up. And so that's the wonder of vaginal hormones. And tell me, Dr. Uloko, about the safety of vaginal hormones, because there is so much misconception of hormones cause cancer, Dr. Uloko. My sister had breast cancer. I cannot take a hormone. Please tell me what you would tell me in the office.
Yes. So that's a fantastic point that you bring up, is that hormones do have a very bad rep. And unfortunately, us as the medical community have to do better about disseminating appropriate information regarding hormone therapy. When we're thinking about hormones, you can kind of break it down into two things. You can break it down into systemic hormones, which are hormones that are going to raise your blood levels of hormones, and three things that we really think about, and the three hormones that we really should be thinking about are estrogen, progesterone, and then also testosterone. I think we always forget, as our society has labeled testosterone as the male hormone, but women actually produce 1,000 times more testosterone in their bodies. So it's also a very important hormone to regulate our overall pelvic health, muscle health, and sexual health too as well. So those are the systemic hormones, and then we then start thinking about local hormones. So those are hormones that are delivered directly to the vulvar and vaginal tissue. So that can either be done through creams, tablets, there's even pills, and then intravaginal inserts as well. And so when we're talking about hormones for the vulva and the vagina, we're thinking a lot about estrogen, but also I'm a strong believer that testosterone or DHEA is also really important and vital to overall pelvic health and pelvic floor health, and then also sexual health. But when we're thinking about urethral health, we direly need estrogen. And so when we think about local therapy and the concern regarding, is there a potential of increasing breast cancer risk? Is there a potential of increasing other gynecologic or endometrial cancer, ovarian cancer, all of those risks? There's no study to date that has proven a correlation with local hormones and gynecologic cancer, so like breast cancer, ovarian cancer. It's actually even recommended by ACOG that you can use vaginal hormones when you're undergoing certain types of treatments and cancer treatments like breast cancer, because it has such negative impacts on your vulvar health, your vaginal health, that oftentimes some people will even stop therapy and treatment for it. But they have then since said that, local therapy is vital, is needed, and it's safe to use. So local therapy is safe to use. Systemic therapy, is safe overall, but that takes more of a discussion with your primary care provider or your sexual health provider.
I actually had this patient on Twitter just last week who wrote to me. I had a tweet go viral, which I am not used to having happen. And she said that I am on chemotherapy for my breast cancer and they keep having to stop treatment because I keep getting drug-resistant urinary tract infections. And so she is actually harming herself by not being on these local therapies to prevent infections so that she can continue her chemotherapy and her breast cancer treatments. And so there are a number of resources which we will put on our sheet, which we didn't put on, that really describe what we know about breast cancer and the safety of vaginal hormones in breast cancer. Do we have a crystal ball and know all information? No, because we haven't put money to studies and really looking at these issues because we don't value women's quality of life and sexual health. And so I don't have a 20-year randomized controlled trial to tell you about, but we have no data, not an ounce of it, to show harm from local vaginal hormones when it comes to any type of cancer. In fact, there's quite a few studies that show long-term use in women with a history of cancer, breast, ovarian, uterine cancer, totally safe and effective to use vaginal hormones. No increased risk of clot risks, no increased risk of cancer progression or recurrence. There are many women with breast cancer who then go on to get pregnant. When you are pregnant, your blood levels of estrogen are 3,000. And when those women get pregnant, they don't have an increased risk of recurrence of their breast cancer or progression of their breast cancer for the most part. And so using a local therapy has not been shown to cause any harm. And so there are many oncologists who may be fearful. They're fearful of using it, but that doesn't mean they have data to say that there is harm. And so the current thinking is first line therapy are moisturizers and lubricants. And so Dr. Uloko, tell us a little bit about that. They're important, they're helpful, they're useful. If you are so fearful of hormones, then yes, we've got some data, but I'm a big believer that moisturizers and lubricants are band-aids that we should use in addition to vaginal hormone therapy. What do you think of that? Can you tell people a little bit about moisturizers and lubricants?
Yeah, so that's a fantastic question. Moisturizers and lubricants are essentially symptomatic treatment. So they're treating the symptoms of vaginal dryness. So they're great options for people that are, just not comfortable with the idea of using hormones, or people that have tried it, didn't work for them, or they're currently using hormones and it's in the interim stage of working and using that kind of as a symptom management, but they are not treatments for the condition. When we know that, so the really interesting thing is that when we know that we have a cure for the symptom, we should definitely try to get down to the root cause of the issue and actually cure the symptom. And the thing is, just twice weekly application of vulvar and vaginal hormones can cure the issue. And so you would no longer need any sort of lubricants or wipes or any of these things as first-line treatment. So really first-line treatment should be curing and fixing the vaginal tissue so that we don't need to rely on these things, or they can be supplemental, but not things that are essentially getting you through day by day. I've had a patient that was in so much pain, could not sit, and was using Vagisil like candy, like was just coating her entire vulva and vagina with Vagisil, and to the point where, you know, she was buying tubes and tubes and tubes a day. We gave her some local estrogen and testosterone therapy, and cured. Like, she can now sit. She's no longer spending so much money on Vagisil, and is now going to be living a much better quality of life. And so when we think about the types of, we have a question about what types of hormones that we recommend. Like I said, luckily there's generic options for local hormones. So there are creams, there are vaginal inserts that can be left in for a month or 3 months at a time. There are pills and tablets that you can also insert vaginally. There is Intrarosa, which is a DHEA intravaginal suppository that converts to testosterone and estrogen. There's also compounded medications where you can get compounded estrogen and testosterone. Those are not quite on the guidelines yet, but we're working to get them there, because I'm a strong believer that estrogen and testosterone are very important for overall vulvar health. But there are so many options for estrogen when we're thinking about it from a urologic standpoint of bladder and pelvic floor health too. So if one option doesn't work for you, we as your providers need to know all of the options so that we can meet you where you are, because this is really vital. It's really, really, really important to consistently be taking the medication. And, you know, if you have questions about where the medication goes, ask your provider, you know, because unfortunately, as people with vulvas, we've been shamed not to know what's happening down there. Take a mirror to the tissue and take a look and apply the medication and really get familiar with your anatomy and learn to love this anatomy. It's really, really spectacular and remarkable, and it can be healed just with twice a week application of local hormones. It's fantastic.
Well, I don't know about everybody on this call. We have 77 people on this call. It's so fabulous that you are interested in learning about this. If you're confused by it, it's because it's confusing. It's because doctors have not done a good job of warning you what's going to happen. We have not done a good job of explaining it. And in fact, the media and physicians have made you fearful of hormones. Whereas when you were on birth control pills in your younger years, nobody was afraid of it. And then when you start talking hormones over 50, everyone gets very fearful. That's why in my practice is I take a lot of time with people. You cannot understand these issues in 10 minutes. In fact, I do hour-long visits with people, and that's not even enough. That I'm actually piloting a menopause day where I spend 7 hours doing lectures and the pros and the cons. I bring in physical therapists, sex therapists, exercise experts to say, what can we do and what are your questions? Because I want to answer every single question. And every statement we make has 20 questions. So how in a 10-minute visit with your gynecologist, when she's doing a pap smear, a mammogram, and a bone density scan, is your doctor going to be able to fully explain all of these issues? And when polled, doctors, less than 7% of doctors feel adequately trained to take care of menopausal issues. 7%. We are failing, and the system has failed you. So if you feel very angry with your physician for not telling you, or your nurse practitioner or midwife for not explaining this, nobody taught them how. And that's why I am, Dr. Uloko and I are tireless. This is my 5th lecture of the day, because there is so much teaching we have to do. We have to be educating providers and patients for knowing that you don't have to live this way. You should not have constipation. You should not have urinary frequency and urgency. You should not have pain with pants. I had a patient who said to me, Dr. Rubin, it's about wearing pants again. I can't even imagine, it's so nice to wear pants again. And these therapies take 2 months to start working. I'll give you this. My friend always says this. When do you get to stop wearing your seatbelt? When do you get to stop brushing your teeth, right? Oh, I brushed my teeth for, 37 years. I'm done now. I did that is the same with vaginal hormones. These are lifelong therapies. The tissue absolutely needs hormones, and without it, you will have frequency, urgency, urinary tract infections, and pain with penetration. And so it's really, really important. We're getting a lot of questions about the type of product. And so DHEA, vaginal DHEA, if not covered by your insurance, can be expensive. It's $85 a month at Costco, so there's some workarounds. Mark Cuban's new pharmacy is an online pharmacy, has generic estradiol cream and generic estradiol tablets that are $10 a month, essentially. And so these are now affordable options, which 2 months ago, I could not have said this. Thank God for Mark Cuban and Shark Tank, because it's incredible kind of what they've put out there. And so the key is using something and using it consistently forever, because it won't start to work for about 2 months. And so there's a lot of questions about breast cancer and blood clots. As far as we know, there is absolutely no risk of vaginal hormones on clots. In fact, I had a Twitter doctor go viral off my tweet because she was a hematologist, and she said, I agree, there is no increased risk of blood clots for local vaginal hormones. And for breast cancer, if you watch, the space, we have breast cancer oncologists who are aggressively advocating for vaginal hormones on social media, because there is so much misinformation out there. And so it may be that your oncologist is really up to date on the chemotherapy, but is not really up to date on the urinary effects and the vaginal effects of these medications. Let me ask you, let's see, Dr. Uloko, how do you manage patients that get a migraine after starting vaginal estrogen? I'm a primary care physician. I spoke with a gynecologist, and she was not aware of DHEA and testosterone. Ooh, Dr. Levin, thank you for being here, and what a wonderful question. What do you have to say, Dr. Uloko?
Yeah, so we definitely get the range of, I definitely have the range of patients where hormones affect them differently. And so if that is the case, we then cut back on the hormones, or the amount of application or the frequency of application, or we switch to something different, because there's different options, there's different ways they get absorbed. And I tell every single patient that hormones are not a perfect science. As we are urologists, we treat men as well, and we give them testosterone, and we prescribe a dose, but it ranges in how it affects them. And so I always say hormones are not a perfect science, and we will always meet you where you are at. So if that means dose adjustments, changing the frequency, or changing the formulary that you're using, that's always an option. And then for one workaround that I do for people that can't, that's a really affordable option, is for my patients, I do a compounded estrogen and a testosterone for the vestibule, and then also for intravaginal.
What's a vestibule, Dr.
The vestibule is, again, this is where I get into learn to love your anatomy. So the vestibule is the site, 90% of where people will have pain with penetration. So the vestibule essentially is the Latin word for entrance. And so it is a special tissue that surrounds the opening of the vagina, the urethra, and it's just right underneath the clitoris. And this is an area that is so important and yet so understudied. It is the site of where most people have most of their pain, and yet it is not taught in medical school, this structure. When we learn how to do this, when we learn how to do an exam, it is not taught, even though this is where 90% of people that come in with pain with sex will.
Do you hear me? Am I still on, Donna? Do you guys hear me? Yes, you hear me. Okay, I'm so sorry. I think we lost Dr. Uloko, but I couldn't tell if it was my internet that cut out. So, all right. So there are so many questions. I'm going to do a segue here. There's been a lot of questions about systemic hormones and if that covers the genital and urinary symptoms. And the answer is not always. So if you're on a cream or a patch or a shot or a pill, and you're having urinary frequency or urgency or urinary tract infections or pain with sex, well, then you may need local therapy. And that's where the vaginal hormones are so helpful and not harmful. It is okay to use them together. And sometimes you have to ask for it because, as I said, less than 7% of doctors get this training. And so encourage your doctors to be menopause certified. Go to doctors who are certified in helping menopausal patients. We love taking care of you and we love helping you through these very important issues. So we are getting tons of questions about libido, and I love to talk about libido because nobody else does. I've been to the doctor many times in my years, and no one has ever asked me about my libido. Nobody has ever asked me if I can have an orgasm. Nobody has ever asked me sexual health questions, and I'm a sex doctor, right? And they all know what I do for a living because, as you can tell, I never stop talking about it. And so libido, desire, the real question is, are you bothered by it? And we need to take what's called a biopsychosocial approach, which means I have to really get to know you. I have to understand your medical history. I have to understand your menopause and your hormones. I have to understand the surgeries that you've had, the medications that you're on. I have to understand all of that. So I'm going to present a case to you that really talks, hello again, Dr. Uloko. I'm going to present a case to you that talks about these issues and how they are biopsychosocial. So I have a patient who is amazing, who is 54 years old. And okay, she's 53 years old. I gave her an extra year. She is menopausal and she came to me being on oral estrogen. So she was on an estrogen pill. And she came and said, gosh, Dr. Rubin, my libido is in the tank and my orgasms are totally muted. What can you do for me? Now, here's the fun thing about this patient. She is one of my very favorite sex therapists in the region. She sends me tons of patients. We work together constantly. Her job is to help patients communicate better about sex. Her job is to talk about date night. Her job is to talk about sensate focus and all of the important psychosocial issues that go on in the bedroom. She has all the tools. She knows the toolbox. She and her partner have a wonderful relationship. It's communicative, it's fun, they use devices, they schedule sex, they do all the things that I send people to sex therapy for. And yet she still showed up on my doorstep and said, Rubin, what do you have for me? And so in working with her, it's so fun because again, she understands the biopsychosocial approach to libido. And so what we did was we were very elegant about our treatment with her. We know that there is research to show that a pill of estrogen sometimes is not good for sexual function. And the reason is very nerdy and very sciencey. When you take a pill, it goes through your liver and creates proteins. Sometimes they're clotting proteins, which is why we worry about birth control pills and pills for menopause that can increase clotting proteins that can cause blood clots. So not only does it increase proteins for clots, it can also increase proteins which bind to testosterone and estrogen to hurt your sexual function. And this evil little protein is called sex hormone binding globulin, or SHBG. Remember, I told you it's totally nerdy. You don't have to remember it. But we have very good data to show if you take the pill away and throw a patch on or a cream on the skin or a ring in the vagina and the hormone goes through the skin or transdermal, it can improve sexual function. So what did I do for my sex therapist, who I love so much? I took her off her estrogen pill. I switched her to a vaginal estrogen ring that was enough estrogen for her whole body, for her hot flashes and her night sweats, and also coated her vagina with estrogen. Alternatively, she could have done a patch and a vaginal insert like Dr. Uloko was just telling us about. She has a uterus, so she has to have progesterone. So I put her on a progesterone pill, which it's an FDA approved natural form of progesterone. There's no increased risk of clots. There's no increased risk of cancer. And she takes that pill every night at bedtime. The nice thing about that progesterone pill is it helps you with sleep and it helps decrease anxiety. So it really does help with a few things. Alternatively, she could have put in a Mirena IUD, or a progesterone-based IUD is another fabulous option. Remember, estrogen grows things. It makes your hair beautiful, your skin beautiful, your nails beautiful. It grows things, but it also can grow the lining of your uterus. And so we don't want the lining of the uterus to get so thick because that can lead to uterine cancer. And so we we have to prevent that with progesterone to keep the lining of the uterus thin. Guys, this is complicated, but we do understand this and we know what is safe. And so I gave her a progesterone pill. I gave her a vaginal ring, which gave her whole body estrogen as well as local vaginal estrogen. And we said, how are you doing? So she came back and she said, Rubin, my libido is back up. I am super happy. This is incredible. My orgasm is still kind of weak though. Like it's more of a blip than a bang. I used to have a bang and now I got a blip. What can you do for me? So I said, okay, we started with this. Let's see, what can we add? And so at that point, we added a testosterone. Okay. We have no FDA approved testosterone for women. It's because the FDA is not so happy with women and they have much bigger hoops we have to jump through than on my male patients, unfortunately. And so I took male testosterone that was FDA approved and I had her use it about 1/10 the amount that I give to my male patients. And she used a tiny bit of testosterone on her leg as a cream every day. And I just saw her last week and she said to me, she said it took about 4 months to work. And that's true with testosterone in men too. It takes about 4 to 6 months to kick in. Remember, your body has to get the hormone in, make some proteins, build some muscle, and it's got to work. And so she said in 4 months, holy crap, Rubin, my orgasm is back to a bang. No more blips, it's back to a bang. So her libido was up, her orgasm was back, and she was still doing all of the psychosocial stuff that she knows how to do. And so she is real pissed, you guys. She is so mad because she has been led to believe that it is all psychosocial in her training, right? She has been told that with just enough date nights, with just enough communication, with just enough of those things, everything will be okay. And she has for herself experienced that that is not true, that it is biopsychosocial. And I think a perfect example, and I saw this on the internet and I thought it was just fabulous. When teenagers cannot keep their hands all over each other, we don't say that they all have deep, meaningful connections. We don't say that they have incredible communication skills. We say they're hormonal, right? It's always hormonal with these crazy teenagers and their hormones raging. And the answer is on the other side of this, it's probably a lot hormonal. Of course, the good communication and the psychosocial interventions work great, and we should do them. Everyone benefits from sex therapy, okay? You guys, no one's so good at sex they can't get better. We can all get better at sex. We can all do new things and buy new devices and have more fun with our partners. That's wonderful. But we also have to understand that there is some biology involved here. And there are some ways non-hormonally that we can boost sexual function. And sometimes we have to be creative. There are some antidepressants like Wellbutrin or Buspar that can boost sexual function. There are 2 FDA-approved medications for low libido in women that work great, but they're approved for premenopausal women. And so we have to use them off label. They've been studied. They're approved in Canada for postmenopausal. Well, one of them's approved in Canada for postmenopausal women. And if it's good enough for Justin Trudeau's country, it's good enough for my country. And I often will use it off label. And so we have options, medical, biological options that can really help. Sometimes hormonal, sometimes we got to switch things around and be creative. Sometimes non-hormonal options, we got to boost dopamine in your brain. And of course, always the psychosocial options. So what questions are coming up, Dr. Uloko? And sorry for that little break. I wasn't sure if she was gone or I was gone or what was happening, but we're back.
It was me. My phone was heating up, apparently. Talking about menopause gets too spicy for iPhone.
Hot and bothered. It's a hot. Your phone had a hot flash.
It did. Okay, so I think this is a really fun question. One doctor told me to use it or lose it, but another said never have sex if it hurts. Who is right?
Oh, I love it. I love this question. I know Dr. Uloko loves this question too. I think that is one of the more offensive things that people say. If you don't use it, you lose it. The idea that a phallus is somehow the savior of your sexual health and sexual being, that's what's implied. And the answer is absolutely not. Yes, pelvic floor, hormonally, the tissue does need to be healthy. So I'm a big believer in giving local hormones. And then if the muscles are tight or if there's pain or discomfort, there are tools and devices like dilation or wands tampons or a sexual aid devices that can be helpful to relax those muscles. And I know Dr. Uloko and I use a pelvic floor physical therapist on speed dial. And just like if you hurt your neck, you get a knee replacement, you go to physical therapy, you can do rehab for your pelvic muscles. And it is life-saving for patients with urinary incontinence, your prolapse, pelvic pain, or any sorts of hip or low back issues. It can be extremely helpful. So we can put a link to how to find a pelvic floor physical therapist in the chat box.
Yes. Yes, I think it is. I like to use the analogy of I have a lot of friends that are orthopedic surgeons, and so let's say that you have a knee replacement. So the surgeon helps you to actually replace the knee, but then you'll then need so many different players that go into your recovery. You need a physical therapist to help you strengthen the muscle around the knee. If you're an athlete and running, you then need to start slow and start working this very slowly. And that's kind of how I approach sexual health and vulvar health. And when we think about sex and how things go, it's a team sport. We need many players involved in order to get optimal sexual health. And oftentimes it's not going to be one fix. It's going to take so many players and time and patience, because the sexual response, this glorious thing, is complicated. And in order to treat it, it does take more than one thing. And so sometimes it might feel frustrating. And I often tell my patients, okay, work with me here. We're with you together. Your goal is my goal. And it's going to take multiple people in order to get us to where we need to be and get us to your quality of life that you want. So whether it is dilators to help, because ultimately, if you think about it, you need healthy tissue. So healthy tissue, that can be whether it's local therapy with whatever local therapy you want, you need first healthy tissues. Then you also need healthy muscles. Healthy muscles need hormones, but then they also then need to learn how to relax and contract. And so that needs pelvic floor work as well. And then, life happens. We're currently living in a global pandemic. Like, war is actively happening right now. And so you need that psychosocial aspect of, last thing on my mind as of right now is sex, but I still want to have it, but how do I cope and heal and figure that out? And that's where the psychosocial aspect of things come into play. There are so many factors that go into the sexual response, and it's going to take time to get to where you want to be. But if you have dedicated doctors, they're going to work with you.
I think that's such a good point. And I think the key is not one doctor is going to be your savior. I am nobody's savior. I am a tool in the toolbox to help as many patients as possible, but I use my friends all the time to help me. And I have a lot of friends, thankfully, all over the country where we try to get you to the right place with the right person. And I think it's really important to know that one visit once a year for 10 minutes is not going to be the answer for your sexual health problems. Sometimes you have to advocate for yourself. Sometimes you have to find a different doctor who's menopause certified, or iswish.org, which we'll put in the chat box, will help you find a provider who does sexual health specifically. But you have to find people who really care and want to listen. And that's challenging sometimes, which is why we don't sleep. And all we do is try to train people so that more providers know how to do this and care about this. It was Dr. Uloko who taught me that as urologists, we are uniquely trained to care about quality of life. It's usually with our male patients, right? We love talking about quality of life when it comes to urination, prostate health, and sexual health. And so that's not always the case for women's health, unfortunately. And so we must advocate for it and demand it and say, listen, my quality of life matters. And COVID has been helpful in making us realize that some of us are willing to take risks and some of us are not willing to take risks. And it's sometimes we as humans are very bad at understanding what is a higher risk. Did you know you have a much higher risk of breast cancer if you have one glass of alcohol per night, if you smoke cigarettes cigarettes and have 1 glass of alcohol per night, your risk is astronomically high compared to anything like systemic hormone therapy, which does not increase your breast cancer risk. Estrogen showed no increased risk of breast cancer risk. In fact, women on oral systemic estrogen had a decreased risk of getting and dying from breast cancer. And even women with breast cancer who have been on hormones do better and have better outcomes ultimately. But that is nuanced. It doesn't make the media, and you don't often see it on headlines. And so we have to undo so much trauma from all of the decades of us giving misinformation, and we caused some of it. And so it's really hard to be a patient in this space. It's really challenging. And you're kind of told to just suck it up. You're told that, gosh, your mother went through it and her mother went through it, and you got to just suck it up. This is just a part of aging. And yes, it's aging, but how you deserve a sexual health, you deserve a quality of life if you want it. It's not about your partner. It's about what you want. And so I think hormones have a very bad rap. Not everyone can use hormones. And so non-hormonal approaches to libido are very important too. And so antidepressants, we know, can cause sexual side effects. In fact, I see a lot of questions about my antidepressant. It delays my orgasm, it hurts my arousal, and it tanks my libido. And so if a medicine can hurt your sexual function, could a medicine help your sexual function? Dr. Uloko, what do you think of that question?
Yeah. It's a challenging question. So when we think about, especially when it comes to medications that are very vital, like antidepressants, because overall we want your mood to be stable, and the brain is our biggest sex organ, I always say. And so if you're not stable from a mental health standpoint, that's my biggest concern. But there are options when it comes to antidepressants that are more sex positive, or don't necessarily affect the sexual response as much. So Wellbutrin, Buspar, like Dr. Rubin had mentioned earlier. And then there are newer SSRIs that don't necessarily have the severe side effects of decreased sexual desire. And so those are the newer options out there that you can talk to your provider about. Then let's say for those that can't get off of their antidepressant, yes, there are options in order to help you from a low libido standpoint. The first one, when we think about it, are the correctable options, or we do a comprehensive exam, make sure all your lab works are fine, make sure all your hormones are fine. If there is any sort of hormonal imbalance or abnormal hormones, we would then correct for those first. And then second line, there are medications that are geared towards low libido. And so those medications either help to raise dopamine or block the effects of serotonin. And then third line, other options that do the same thing in terms of raising dopamine, or oxytocin. These are more off-label uses for the treatment of HSDD, and they're very specialized off-label uses. So I will phrase that and really emphasize that. But there are options for the treatment of hypoactive sexual desire disorder, or HSDD as we call it. And so even if you are taking an antidepressant, talk to your provider about whether or not they could switch you to a more pro-sex, pro-interest SSRI. And if not, there are options outside of that.
Another thing that I love using with patients in my practice is devices. Listen, sexual technology, as we call it, sex tech, is a booming, wonderful industry now. It's not like the old days when, there used to be newspaper over the windows and you had to be awkward going and feel like a criminal going into one of these stores. You can go on Amazon and buy a fabulous device that can be really fun to use in the bedroom. And we know clitorises love vibration and can help with orgasm. And we're urologists. We're here to tell you penises like it too, because essentially a penis and a clitoris is exactly the same thing. They're made up of the same tissue. They work the same way. It's just that women don't typically penetrate or pee through their clitoris, so society has not really cared about them. And so working with vibration, working with devices that stimulate the clitoris can allow for so much sexual pleasure and enjoyment and couples enjoyment. And so I see patients all the time who come to see me and say, Dr. Rubin, I'm broken. I can't orgasm from penetration. And I just look at them and I say, wait a minute. You and 82% of all women, most women can't orgasm with penetration. That's normal. It would be like taking a man, rubbing the inside of his thigh and expecting him to have an orgasm. It's close to his penis, but it's not his penis. And he certainly won't have an orgasm from just thigh touching, most of them, I would say. And so similarly, the vagina is near the clitoris, but it is not the clitoris. And so most women, the majority of women, need clitoral stimulation for orgasm. There are a few unicorn ninja, incredible humans who are able to orgasm from penetration, from the top of the vagina being stimulated, from cervical orgasms, uterine orgasms. That is not the norm. If you are one of those humans, you are very lucky and you should have many, many orgasms and enjoy them. And if you are not one of those humans, you can explore to find out if you can become one of those humans, but you are not broken. It is totally normal and you should enjoy all the clitoral stimulation, and we should stop calling sex just penetration, because your orgasms are just as important as your partner's orgasms. In fact, people with clitorises can orgasm multiple times, and you should have more orgasms than your partner should have if your partner has a penis. And so I'm a big believer in orgasm equality. I think we can fix the pay gap if we fix the orgasm gap. And so I love devices for my patients. What about you, Dr. Uloko?
I am a huge fan of devices. So one thing that I really care a lot about, the social construct of where we're at, and kind of, we have a problem, how did we get here? I think Hollywood plays a huge role into how we view sex and sexuality, and the fact that we don't teach sexual health in our country is ridiculous. Because we've all seen The Notebook. We've all seen where she's up against the wall and he enters her and she orgasms. We've all seen that. That does not happen. Sex does not look like that. Sex looks like so many different things, and yet we only see it done one way. And so when we see it done one way, that's the only thing we know how to do. And then when it's not working because, oh my God, he's not Ryan Gosling and I'm not Rachel McAdams, like, you think something's wrong, and it's not wrong. Like, I had a patient that was terrified of devices, and her husband really didn't want to have sex. It just wasn't something that interested him, but she really wanted an orgasm, and it was such an issue of strife in their family. And I was like, have you tried the magic wand? Like, let's sit down and talk about this. And it took a lot of, literally come to Jesus talks, because there was a big religious background there. And we finally got down to the fact that, in this case, God had made a vibrator, so she can use it. And so the next time I saw them in clinic, she had learned how to use a vibrator night and day, just absolutely. So her outlook in life had changed significantly, from crying in my office to just like high-fiving everyone, and so sex doesn't look one way. Getting to sexual pleasure is whatever works for you, whether that's eating a hoagie sandwich in bed or a great vibrator. Whatever works for you, you should do it, and stop conforming to whatever society tells you, and find out what works for you. And that's, again, why I say get really comfortable with your anatomy, because once you start getting comfortable with yourself, then you can start getting comfortable with the idea of being a sexual being. So, big believer.
I think that it's such a good point. And something we see is there's no age with which this stops being important for many people. And so to your point that you don't have to look like Ryan Gosling to deserve good sex, right? I have a patient who I spoke to recently, and he said, well, Dr. Rubin, I can only keep my erection if I am standing up. Otherwise, I lose the erection very easily. And so my new partner and I, he's in his late 70s, he said, my new partner and I have adjusted our routine, and she comes towards the end of the bed and I stand up and I penetrate that way and it works. He said, but I'm worried about slipping and falling and breaking a hip. So I wear sneakers so that there's tread on the ground and so that I don't slip. And we laugh about it, we giggle about it, and we have great sex. And it was just a magical story because, again, sex becomes important and it looks funny and it's awkward and it's silly and weird noises comes out of your body and you change, your skin changes, your health changes. Sometimes you break a hip and have to try a new position. And so understanding that sexual health is just health is the most fundamental, important point of all. And so with that, we are going to bring Donna back on. Thank you for supporting Let's Talk Menopause. Thank you for coming and spending your time with us today. This has been an absolute honor. And we see that there are so many questions. You should have so many questions. And we will continue to answer those questions. And please talk to your friends about this. Talk to your colleagues about this. Talk to your children about this. We should not be secretive about this and take the private parts away.
Amen.
Yeah, go ahead, Marie. Did you want to finish up?
No, that was mic drop, Rachel Rubin. Love it.
You guys are incredible. Really, we thank you so much. We could have gone on for hours, I think, but this is not the end. This is just the beginning. We are, let me just make sure, I don't know if anyone can see me. There we go. Here I am. So we put in the chat a couple of things. One is a symptoms checklist that you can bring to your provider. It has all the different symptoms on there, from the sexual side effects, UTIs, to mental health symptoms, to physical symptoms. And we created this as a tool for you to start the conversation with your doctor, because unfortunately, not every doctor is like Dr. Rubin and Dr. Uloko, and we have to bring up to them, especially around sexual side effects. In fact, I just launched the poll to ask you guys, has a doctor ever or provider ever brought up sexual side effects from menopause? So I'll be curious to see those results. So we put in the chat a fact sheet, and in that fact sheet is basically what Dr. Rubin and Dr. Uloko talked about today. Again, it's not everyone needs to talk to their medical provider. We also gave information for people to go onto ISWITCH and through our website to get to the North American Menopause Society to find a menopause informed provider. So just to let people know, we're going to be holding these menopause talks monthly. We will have this menopause talk, if people miss part of it or want to share it with people, on our YouTube channel, and you'll be able to get to that on our website, letstalkmenopause.org. In the chat, I also gave you Dr. Rubin and Dr. Uloko's Twitter and Instagram handles, and both of them are really active on social media and say all these things. So I would really encourage everyone to follow them. And if you're in their location, San Diego for Dr. Uloko, so Southern California, and Washington, D.C. area, to have them as providers. And we will also, continue to have them involved with Let's Talk Menopause and answering a lot of your questions. You can also go onto our website. Both of them were interviewed, and so their interviews are on our website on Ask the Expert. Another thing is we're going to be having our next menopause talk on urinary symptoms of menopause, so increased UTIs, which we covered briefly here, but also urinary leaking. And we're going to have two fantastic doctors, Dr. Jocelyn Fitzgerald and Dr. Cheryl Iglesia, who I think both of you know. So we're having the experts on. And then after that, we're going to have an amazing two-part series on hormone therapy. So I know in the chat, lots of people were asking about hormone therapy, and there's a lot of misconceptions and a lot of questions. And so we're doing a two-part series with Dr. Lila Nachtigal and Dr. Margaret Nachtigal, who are amazing, from NYU. And Dr. Lila Nachtigal is like the queen of menopause. So we're so excited to have the mother-daughter team on there to discuss hormone therapy. The first one's going to be an overview, and then the second part's going to be more on individualized treatment. And so look forward to that in April and May. So visit us at letstalkmenopause.org, sign up for our newsletter so you can get all this information, sign up for follow Dr. Uloko and Dr. Rubin on social media, and I think that is it.
Goodbye and God bless you.